much. Thank you. I wish I would have been there physically to meet all of you and have a glass of wine with all of you. But somehow circumstantially, I could not make it. But I'm happy that we are still there virtually, and we look forward to having a physical interaction in very near future. So with this, my topic of discussion today will be uh, related with uh, the robotic surgery, which we all know that it is the future as it appears today. So I would also like to give a little brief on how the robotic surgery came into the minimal access surgery platform and how it clicked and how it refused to click for more than 2 decades. And as the title you see, the modular robotic platform. So the secret is the modern robotic platforms, say for example, Versius from Cambridge Medical Robotics and some of the Indian-made ones, I think has come into picture, changing the whole uh, uh, concept of robotic platform. So robotic surgery has been quite effective and useful, but it did not pick up as we expected it to pick up because of the platforms which was not really as conducive as with us. And I'm talking about the Da Vinci robotic platform. So I think the first word robot was used in the Czech Republic, and it is 1921 that the word robot was introduced. And the word robot was used for the designated group of the workers, and they were supposed to do exactly what was instructed to them, irrespective of difficulties, irrespective of time, irrespective of the circumstances in that situation. For example, somebody has been asked to clean the wall, so till he cleans the wall, it is his responsibility. And there was no ifs and buts in this. So that is how the word robot came into 1926. And they were the type of workers who were forced to work without even asking the question. And today, I think we are talking the same robots, which are mechanical device. Now, Puma 560 was the first robotic surgical robot system, 1985, and it was for localization, neurological localization, and for biopsies from the brain tumor. So it had its own impact, and I'm sure a lot of people, a lot of patients were benefited because of exact localization of the brain tumor. Then came the ESOP in 1990, and I think some of our senior colleagues will know that I used to use ESOP, which was a voice controlled and foot controlled camera holder. So this camera holder used to be interesting, though not in India with us, because we have got a lot of our younger colleagues who are keen to assist you and you do the camera work. But ESOP was a very interesting feature, and we found it very fascinating that with paddle you can zoom in, zoom out, turn left, right, rotate. So it was quite interesting and fascinating, not realizing that this is going to be the first laparoscopic robotic system to control the telescope. Then came, of course, 1995 Zeus, which was bought by Da Vinci, which came into picture in 2000. The Da Vinci, which is, I think all of you are quite familiar, and this is a very popular robotic system for the urologist and oncologist. And it is just a matter of chance and pride for India that I was one of the 12 surgeons who were requested to for the FDA approval for the Da Vinci system. And it was in Cincinnati, USA. 12 of us, we collected for a week, and we used the system on various types of models. And then we approved the Da Vinci system for the use, clinical use. And then we saw the merger of the Intuitive and Zeus platform, which was mainly used by the Stryker company. They came together, and that is how the strength in robotic surgery came in. Now, I think it's very important to understand who is the potential surgeon who should be doing the robotic surgery. So, a lot of time it has happened that conventional surgeon that who were not using laparoscopy started using the robotic platform, and that was a sort of mistake which was realized much later, couple of years later, that they were not really able to do the case completely, and also there were a lot of complications which took place because of the lack of experience of laparoscopic surgery. And then started the laparoscopic surgery, started the robotic surgery, and that was the big success because uh, they knew the laparoscopic principles, angles, etc., and that is how they could realize that robotic surgery is meant for the laparoscopic surgeon because it is a laparoscopic robotic surgeon. And then came the telerobotic surgery, which was in 1994. Fortunately, I was also part of it uh, it was by Colonel Satawa in since US, and that time it was known as a telerobotic surgery. So the surgeon was looking visually, and there was a, if you see here, there was a robotic, this one, this was a robotic system which was remotely there, and the hands had the gloves, and the surgeon was also wearing the same gloves. So whatever the hand movements were here were reflected in the robotic arm here. And this is which we did. And the first such experiment, which I was also fortunately part, was in 1994 in Orlando. And I was quite inspired that hopefully this may be the future for remote surgeries. And then we moved on and created the Department of Minimal Access, Telerobotics and Cyber Surgery, because the cyber surgery was done for the uh, astronauts who were in some other countries, some other place, also in moon. And I'm so happy and delighted that you can see all my colleagues here who are the now the most experienced laparoscopic surgery surgeon in the country and also abroad. You can see Dr. Anil Sharma, you can see Dr. Kullar, Dr. Vandana, Dr. Manish. So this is a core group we made, and this is the board which says Department of Telerobotic with all our names there. So which is a big pride. You can see Pankaj also here. Pankaj was also coordinating with us. And who else? I think practical also, yes, you can see Enu also here. And our Rashmi, who is to our fellow. So we started our first department in Asia Pacific region in 1996, exclusive for telerobotic and cyber surgery. So of course we changed our approach, and when we start thinking about the technological improvement, we thought that the telerobotic was not working, and there was some evolution which were taking place, and we thought that we are going to be part of it, and that's how we. So this is my first slide. About 33 years back, when I started laparoscopy, I thought that is a great leap of faith. So please see the difference. It was a great leap of faith, and this faith had no technological basis. We were moving from conventional surgery into the laparoscopic surgery and thinking that our outcome will be something like that. And now with pride, after more than 3 decades, we can very proudly say that yes, it was the early leap of faith, which now proved laparoscopy as the worldwide accepted method of operating in not only abdominally, chest-wise, neck, and various joints, which are the common this endoscopic surgeries which are done. So then came now our 2 years back, we had another great leap of faith. And that leap of faith you can see is not this thing, but associated with a lot of technology. You can see the ropes, you can see the system, the 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 leaping system. So this is how the difference took place. First, we had a leap of faith without any gadgets, and now we have got leap of faith with such a sophisticated gadget like the robotic platform. So this is the difference between the two other these things. So now I think, in one word, if I have to say today, I would say, I would say that we should think laparoscopically and operate robotically. And that is the way forward for us now. So once again, think laparoscopically as we all are doing today and operate robotically, which we are going to do. And especially for the younger surgeons, it is very important to think laparoscopically and get opportunity to do robotically. I'm sure sooner or later, all the hospitals. So this is a virtuous system which in our institute we all are using it, and you can see the uh, 3, 4 arms which are mobile arms like elephant's legs. They can be moved from places to places, and you can see the console here, and this console is open console, not like Da Vinci console where you had to put your neck into that tunnel, but it's open console. This console can go up and you can stand up and operate, or you can sit up at your convenience at whatever height you want. This is one. Second thing is all these things are mobile, as contrary to the Da Vinci system, which was fixed in one operation theater. We can move this Da Vinci robot, the Versus robot, from one operation theater to another operation theater. In our institute, we run 365 days, 5 operation theaters every day, so that because of looking at the workload, which is almost about 350 surgeries every month and about 4,000 surgeries every year, we need multiple operation theaters. And this robotic system moves from one theater to another theater, and the console also moves. So you don't waste time in between two operations. So that again is a very, very important aspect, and that is why it is known as next generation robotic platform. So you can move it from one floor to another floor, one operation theater to another operation theater, one operation building to the next operation building. So I think this way it gives the cost effectivity first, and mobility second, and multi-disciplinary approach, and can be moved from places to places, and even from city to city. So this is a great advantage, and we are taking that advantage and enjoying the robotic surgeries. Another good advantage of this is the sort of pistol grip which we are used to in our instruments. So you don't have to use fingers, but the fingers are used to control. There is a clutch button, there is a thumbstick which you can see on this, and I'm sure you will be exposed very soon to this sort of platform all across. So ease of use and ergonomic hand movements with your uh, uh, arm sitting on the platform, and only wrist is being used for the control of the instruments. Another advantage, as our passion of our institute for training and teaching, we are able to let the number of young surgeons sitting behind us and using the same specs, they can see the hand movement, they can see the screen, 3D screen. So this is the ideal way of training and teaching. But in the previous generation, you needed another console where one person can sit and learn. So here, any number of persons, doctors and surgeons can sit behind you and learn out of this. This is another advantage which which makes it a next generation robotic system. And I'm quite convinced that all SSI platform, SSI robotic system, Indian robotic system, and all these will follow the same principle. And this is the future of the next generation. And suddenly we realized that it became the gold standard now. Now, of course, laparoscopy, even if you look at your practice, the commonest practice is for laparoscopic cholecystectomy, and then comes hernia. And between cholecystectomy and hernia, and of course the pelvic surgery like hysterectomy, etc. These are the common surgeries, and this next generation platform is the most ideal system which are going to use for number of simple procedures, common procedures, as well as the complex procedures like radical surgeries and bariatric surgery. So we are using it for practically all surgeries, laparoscopic surgeries, which we were doing in the past. And we have a very high volume robotic surgery institute. Now we are doing almost 70, 80 surgeries, which includes gallbladder, hernia, bariatric, and appendicular surgeries, and all surgeries which we do. And we are seeing a tremendous trend change in these things which are happening. So I think we are on the fortunate side where when we started laparoscopy, uh, these four things were commonly said. It's a high cost, it's a limited availability, lack of expertise, higher complications. So this was about 30 years back was told about laparoscopic surgery. And exactly the same thing today, we may be talking about robotic surgery. High cost, limited availability, lack of expertise, higher complication. So, but I can tell you that future, it took 30 years for laparoscopy to prove this. For robotic surgery, is going to 2, 3 years, 4 years, at the most 5 years. And 5 years later, when you hear and attend the congresses, you will be talking about robotic surgery, which is average cost, lots of available robotic systems, and lot of robotic surgeons in the country and in the world. And the higher complication will become the lowest possible complications of laparoscopic surgery. So this is my way of projecting it, and I'm sure a couple of years later you will realize that this particular slide has impact in our laparoscopic arena. And you can make out yourself. I think Da Vinci robot got FDA approval in 2000, which I just mentioned. But 22 years later also, it has only remained concised and used by the urological surgery for most commonly the prostate cancer and the pelvic surgery by the gynecologist as well. So this is how so many years back we started. But challenges in 2000 were cost, training, indications, availability. Every used to say, what is the indication? Not mentioning about the three-dimensional image which you get. Again, there was a jump from the conventional two-dimensional laparoscopy to the robotic three-dimensional laparoscopy. But I think the hassle was definitely the major capital expense, because that system used to be very expensive, and today's system, next generation systems, are 40-50% of the previous generation. And previously it was used for selective procedures. Now it is used for all common procedures, for which most of our audience sitting here are mostly for the common surgical procedures. And morbidity, as practically as a laparoscopic surgery, whatever is the morbidity of robotic surgery is much, much less, because it being the three-dimensional surgery. Manual use in general surgery procedures were there, but now we are using it maximally. Now, just to give the international picture, what sort of evolution is taking place, because most of us, we are not familiar unless we are projected. And this is the study which I am talking about was from 2012 to 2018. And today we are sitting in 2023. So anything and everything shown here will be multiplied many, many times. So now, look at, I think, robotic surgery. The robotic surgeons, the number of robotic surgeons has increased 400%, more than 400%. So you can imagine in the hall, all of you are sitting, maybe another year or two at the most will be the robotic surgeons. No more the laparoscopic surgeon, but robotic surgeons. So be prepared, and I think be prepared to get your visiting cards changed to the robotic surgeon. And this is what is going to happen. This is not too far. Now you see the surgeries. The general surgical procedures have been mainly important for the push of the robotic surgery. And there are increase of 840% increase in the number of robotic surgeries which are done across the globe. Another interesting is inguinal hernia. And I would also mention the ventral hernia with the modern robotic system. So the number of inguinal hernia repair has become robotic. 4,110% more cases are being operated robotically across the globe. You can imagine the figures what will be now, because this is up to 2018. But if you look at now, I think it must have increased to 10,000, 12,000 procedures of inguinal hernia done robotically. And it is not only the surgeons who are doing it, but the hospitals have got a robotic system. The patients are asking for robotic surgery. So it's a big, big push. And you should also be prepared. All this is hernia surgeons. You should be prepared and try to take time and acquire institutions, robotic surgeries for your institution. And it is going to be much, much cheaper in the future. Now, ventral hernia, because of the suturing involved and abdominal wall involved, has increased 4,480% to be done robotically. These figures, it seems to be unbelievable to us, but these are the facts, and I have given the reference. You can go through the reference and read about it. And as I said, this up to 18. Now we are talking of 2023, and they would have gone many, many times. Now, anti-reflux surgery, the number now is more than 800, so it's almost 860 a percentage rise in that. Same thing did not happen with cholecystectomies. And this again, I would like to point out, though it was 300% more cholecystectomy were done robotically from 2012 to 2018. Again, astonishing figure. But today, if I talk in 2023, keeping our institution itself, I would say 33 to 40% gallbladder surgeries are done robotically, not by only our choice, but by the demand of the patients. So I would like to insist and emphasize to all of you that please, unless you get into this, and like it has happened in robotic surgery, it will happen, it happened in the laparoscopic surgery, because gallbladder was a commonest surgery, still remains the commonest surgery for anybody. Same thing will happen. The more and more patients will all the surgeons who wants to go into robotic surgery will first train themselves for robotic cholecystectomy and then move on to other procedures, because robotic cholecystectomy and robotic procedures are quite different than the laparoscopic procedures because of the instruments, their use, the use of technology, the use of movements, angles, etc. Now, again, this is a chart where inguinal hernia, ventral hernia, anti-reflux surgery, how they moved from 0.7% to 28% robotically. But at the end, I would like to emphasize that cholecystectomy used to 2.5%, today is 7.5% increase. And next year, it is going to be almost 300%, because more and more institutions are having robotic system, especially the next generation, and they are able to do many procedures. With the previous system, I think you could do just 1 or 2 cases because the system was fixed in the operation theater. But now you can move, you can finish one surgery and move on to another operation theater. And this way, in our institution, in couple of days, we have been able to do even 10 robotic surgeries in 5 operation theaters because of the mobility of the next generation system. So where do we stand now? It is very important that we may think that robotic system is available only in few centers, but over a period of time, we will realize that it is going to be going much, much bigger. Global system, you can see that how the robotic platforms and market is increasing. and this is just expected in 2025. So need, what is required is the easy availability. Cost per patient is going down, and it is go even further. And you need a mobile system and a good training platform. Our experience now, you see, has gone from graph itself says how our experience has moved uh, very quickly. Every month we are doing more and more robotic surgeries there, and we expect almost about 100 to more than. And before we realized, in 2022 we created two world records of robotic surgery: the fastest 100 robotic surgeries and the maximum robotic surgeries in the world, by one particular system and one particular department. So with all this thing, my best wishes, and I will insist that all our colleagues, younger colleagues and not so young colleagues sitting in the audience, would like to get into this next generation system and next revolution in the field of the surgery, from conventional to laparoscopy and laparoscopy to the robotic system. And all the best, and hope you will enjoy the days of your experts discussing with you on various intricate procedures and also the common procedures. All the best.
Thank you, sir. It was a very illuminating lecture. Everybody was spellbound, and we wish you an early recovery. We want you to be back in physical form with us, and thank you so much. And I think you can hear the round of applause. It's a big round of applause.
Thank you very much.
And everybody is wishing you an early recovery, sir.